Thanks so much. Thanks, Yannick. I I'm so excited to be here, and thanks for inviting me. Sorry I cannot be here in person with you, but I'm so delighted to be able to share a little bit of this story. It's a little bit of a journey of stress MRI, which is sort of as you know, is a sort of a newer tool in the last 20 years compared to many existing technique. And I again appreciate that this opportunity to share our journey and the new developments over a couple of years. So um, here's my just here's my disclosure. I will mention some AI applications that you're very familiar with because it started developing in Stanford many years ago, but I have no financial relationship with that AI effort. So let me just spend a few slides to uh, justify why we need a tool that is highly accurate, highly physiologic on the myocardial level. And I think CMR really is a very strong contender in that regard. Because traditionally, I mean, the way we should think about coronary disease or angina, patients with disease with or without the diagnosis, who present with angina. I think we have there are many lessons learned, including the ischemia trial, courage, BARI 2D. We all learned that it is a fairly benign condition as long as the angina is not accelerating and is controlled, and many times can be controlled with medical therapy. In this Clarify registry of 32,000 patients followed for 5 years, and these are moderate to high risk patients with moderate coronary stenosis confirmed. The point is that if we treat them on medical therapy that push towards secondary prevention, that is a very reasonable strategy. And most of the patients, almost 40-50% of the patients, it will take a while, but it will in the next few years, as long as they're not going into an accelerated pattern, they actually fare very well, and most of them achieve angina-free state, either spontaneously or some with medical management or coronary revascularization. So what I learned from this lesson is that we have to be patient. We have to be patient when we deal with patients presented with stable angina or coronary disease with atypical symptoms. It is really those patients who fail to achieve angina-free state, it's in blue here, or they accelerate, or they develop LV dysfunction. Those are patients that we really have to act more quickly. So what I learned is that with the current highly effective medical therapy, we really should be patient, give a little bit of time, maybe not jump to diagnosing with cath, and just treat with medical therapy and explain the situation with the patient and follow the courses. As we have shown, as we have learned from David's great work in the ischemia trial and other trials in the past, such as Courage and Barry 2D, we know that for every Americans that are diagnosed to have coronary disease that we sent to cath and found to have cath disease, for every one of those patients, there are 20 more people upstream uh, who presented to a primary care physician's office or general cardiologist office and ended up getting because of chest pain symptoms or chest pain equivalent type symptoms, and ended up getting some sort of non-invasive testing. Now, historically, because of the fear that we're missing something, we're missing ischemia, so therefore the patients will do poorly, then we ended up doing a lot of these tests. We're talking about 12, 15 million of non-invasive tests that upstream before we cath. So this is a big problem, and not only about cost, but if you look at that, is that we spend so much effort and healthcare resources on non-invasive testing when the risk of a bad outcome, unstable angina or acute MI, is only in the order of about 1 to 2% per year. So we certainly have to be a little bit more selective and learn what these technology actually can bring to the table. Now, historically, again, the way we think about disease for decades is that we think that by looking for some ischemia, small amount of ischemia, looking for stenosis, and we go and send them to the cath lab, intervene on it, and geographically stent it or PCI'd it, then the patients would actually do better. That era has, with many of the trials now, shown that that's actually not exactly correct anymore, because one, the prevalence of disease, patients are overall getting healthier. We are in an era that patients look after themselves better with their very effective medical therapy. The diagnosing a severe ischemia rate has dropped tremendously from 30, 20 years ago to down to about 5% now. So in the era where there's a very low disease prevalence, if we just aim for high sensitivity and send people to the cath lab, that's I would argue that that's actually a wrong strategy. And instead, we should be looking for tests that are that will allow us to be very sure about these patients that we send to the cath lab will indeed get a PCI based on physiologic grounds, will indeed feel better, will indeed feel better and do better clinically. So I would argue that the area that we need to focus on is really to look for high specificity towards functional significance of CAD, not just coronary, not just stenosis, but functional significance of CAD. Historically, we have not done well. From the ACC NCDR registry, about almost 400,000 patients who get a cath, we know that because the way we use cath lab, we send patients with a low threshold to invasive assessment. Almost 60% of these patients have ended up not getting any kind of intervention. Now, whether they were prompted by a non-invasive test or not didn't seem to make a difference. So that is retrospective data. So it's hard to argue how whether the non-invasive actually had impacted or not. There's more to that, to that story that the non-invasive tests offer. But suffice to say, even despite of that, we know that the way we think about cath lab should be different, should be better guided with better tools. And I would argue that that is something that is highly specific towards the benefit of a intervention at the myocardial level. We also know that looking for ischemia, looking for specificity is really just specificity for myocardial improvement, myocardial reduction of symptoms, which is reflected by burden of ischemia, is only one thing. The bigger picture is that we really need we need better tool to look at atherosclerotic burden. So I think looking at physiologic benefits at the myocardial level and atherosclerotic burdens are complementary. However, I will argue that if you just look at atherosclerotic burden without understanding the myocardial physiology, then you'll end up with still not be able to make good decisions for the patients, because as seen here in this in the Mortensen well-known registry, where they conducted many patients who have stable chest pain patients who follow for a long term. These are mostly CT studies. We learned that it's really the atherosclerotic plaque that drives bad outcome, not stenosis. So it's really the atherosclerotic plaque burden that we have to better understand to guide medical therapy. So I would say that atherosclerotic burden and understanding the physiology at the myocardial level are complementary tools. So I would first propose to you that stress CMR is a comprehensive functional test at the myocardial physiologic level that is relevant in the current era of low coronary disease prevalence, and when we now have very effective GDMT. CMR is a class 1 indicated on par with all other techniques, including PET, in the latest guideline in circulation. It was published in late 2021 in the AHA-ACC supported guidelines across different journals. It has multiple class 1 indications for acute chest pain and the standard class 1 assessment for stable chest pain with or without known disease. In addition, it also has a 2A criteria, 2A support because of its quantitative nature on myocardial physiology, myocardial blood flow burden towards diagnosing suspected ischemia with no obstructive disease, so-called NOCA, which is similar to PET. And I will show some examples that using this sort of technique that we have been applying at the Brigham. If you think about it, look at the assessing coronary stenosis versus downstream myocardial physiology. Certainly, CMR is not the highest in spatial resolution and techniques. The best CMR sequence will give you a spatial resolution about 1.4, 1.5 millimeters, and that's pushing to the limit of the technology. So interrogating coronary level, CMR is not coronary stenosis level. At this point, CMR is still lagging behind, although there are some exciting applications to look at MR angiography. But look at the concept that it takes about 36 pixels to interrogate a stenosis, assuming the vessel is about 3 millimeters wide. But downstream from that stenosis, let's say this is at proximal LAD, 3 millimeter proximal LAD. Downstream from that, we have 60 grams of myocardial tissue that is supported, that is perfused by this across that lesion. So that gives us an opportunity to look at different myocardial techniques, myocardial physiology, and that is much less restricted by their spatial resolution. For a 36 pixels interrogation of a proximal LAD, we have more than 7,000, that is 200 times more pixels to assess myocardial physiology. And that will allow us to play different assessment. T2 for acute edema, late enhancement for infarction or acute injury, perfusion defects, rest or stress, regional function, and then we can correlate those information to make more specific decisions. So what I'm going to try to explain to you is the myocardial quantitative perfusion that Mike also has invested many years of his expertise in this, and it's the tool that is becoming more mature. What it does is, for those of you who may not be familiar with this technology, is that we basically inject a bolus of contrast, and as it goes through the heart, which takes about 20 cardiac cycles, they will enter the heart, perfuse via the coronaries, perfuse the myocardium, and then exit the heart. That bolus, we can capture that over time. And you can generate pictures, high resolution pictures of the blood flow of the myocardium. And using a validated blood flow models, you can capture the flow pattern, which is described here in these curves, between the left ventricle and the myocardium. You can correlate those flow patterns into quantify them into high resolution display of blood flow numbers in milliliters per minute per grams of tissue at the pixel level. Now, with the advent of the CMR technology over time, we have now been able to basically make these sampling of data fast enough over the last few years that it can happen every cardiac cycle. That means that capturing the profile of this flow become a lot more reliable. So not only do you have a blood flow picture that you can see the blush of the myocardium, you also can quantify them, and you can co-register against late enhancement, so you can see where it is infarcted, where there is the extent of the hypoperfusion exceeds the infarcted territory. So that becomes, in my opinion, becomes a very powerful tool when they can be overlaid on top of each other. So here's some of the examples. Some of these are shared with me by Peter Kalman at NIH. This is a normal subject. You can see that qualitatively, you don't see any perfusion defect, stress, or rest, but you can see the blood flow increase several fold into the 4 or 5 range in this normal volunteer compared to a low flow at rest state, as displayed in the color scale. Here's a seemingly single vessel disease, but you can see that there is a perfusion defect qualitatively. You can see that it's very easy to recognize the infraseptal wall is hypoperfused and is reversible. The myocardium is of normal thickness, so knowing that this is viable myocardium. However, the quantitative map tells you that the LAD territory is also also hypoperfuse, which is reflective of a less stenotic but significant coronary stenosis. So seemingly single vessel disease, but it turned out to be the map. The map tells you that there is a higher degree of involvement of perfusion defects. Here's a triple vessel disease, so you can see that. You can also tell, well, the periphery of the epicardium is getting hyperemic compared to rest, as is seen in the orange color. But all the territory, all three coronary territories were hypoperfused in the endocardium. Because of the high resolution of these techniques, it can allow us to, for the first time in the last, I would say, last 5 to 10 years, that we can have these tools to understand better these techniques. Now, here's a example that was just done last year. It's a patient who had a equivocal stress test, has exertional dyspnea. But then when we stress him, there's a clear perfusion area that is hypoperfused here compared to rest. It is affecting the LAD territory, proximal LAD, without any infarction there. So the concern is that there is a tight LAD, significant LAD stenosis. He was sent to cath. It was shown that the cath lab director looked at this and felt that it was not significant, and sent him home and felt that it was an overcall by the CMR. He continued to have symptoms, have to be sent back 2 weeks later, despite of medical therapy. Sent back to the cath lab 2 weeks later, and then now they did an FFR and it showed that the FFR is significant on the FFR. Now, these are the cases you can argue that, well, we should have FFR that right away. But in reality, it's still happening all the time that we base our decisions on qualitative look at the angiography and without a deeper understanding of the physiology and make decisions. The patient was sent home after the stent and become asymptomatic. He basically felt tremendously better within a few days. So that was a qualitative means, but we can actually now, as I mentioned, because of the higher technical value, technical success of this technique, we can have something like this, and this is what we do routinely at the Brigham for a few years now. Although slightly different technique, we can now sample the blood flow every cardiac cycle with consistency, even when the heart rate goes up. So we can have both a qualitative assessment, but also a map. This is a patient with HCM. So you can see that initially, at least to my eyes, the subtle perfusion defect is harder to appreciate. You can see it, but sometimes when it is not properly post-processed with window and level, then you will miss this for a not so severe perfusion defect easily. There is no infarction, no scar in the subtle thickened septum, but you can easily appreciate the hypoperfusion based on the mapping. And also you can get quantitative numbers. These are the myocardial perfusion reserve, which should be in a normal region should be more than 2, but you can see that the septum and the rest of them are, a normal person should get the myocardial perfusion reserve up to 3 to 4, but it's diffusely hypo suppressed, especially in the septum. So not only do we have high resolution at 1.4 millimeters in plane now, that we can assess endo and epicardial pattern, we can see the hypoperfused spatial pattern and sample for high blood flow, high sample at a fast enough rate to reflect accurate blood flow by MR and compare against the scar pattern. How good are these qualitatively? Now, qualitatively, what I'm going to show is some of the basic data in the prognostic side about how we have been able to deliver this in a sort of a more general population or more general practice. You can't say it's really real world because this technology is still limited by somewhat experienced sites who can actually do this stress CMR. We conducted a study back a few years ago across 13 U.S. centers, combining the effort of data, pulled together about 2,300 patients So we looked at the outcome over 5 years, and these patients were scanned as clinical means. The one thing we observed was that this is a good tool, even qualitatively, can be used to say if it's negative, no ischemia, no infarct, if the LV function is normal. Again, this is relevant, right? Because the current era of prevalence of disease is low. So we found that in about 67% or two-thirds of the 2,347 patients, they had a completely normal MR, no ischemia, no wall motion abnormality, no scar, and they enjoy overall very low rate, less than 0.6 to 0.7% per year across all 5 years of primary outcome of having an MI or cardiovascular death. But you can see that you can scale the risk in the first year and the subsequent years. But in the two-thirds of patients, there's no justification for us to not just continue treating with medical therapy in the primary and primary prevention. We also understand that um, the need for patients over those same 5 years, if they were followed carefully and follow their symptoms, the need for revascularization is also very low. There's a 3%. Overall, it's about 1% per year across all 5 years. The second year, there are some patients who were cath and was intervened, again, not based on physiologic grounds. But overall, the need in those two-thirds of patients in the more than 2,000 patients, so this is about 1,500 patients who had negative MR, they also did not really need any intervention. We know that the tool, compared to looking at the angiogram or looking at a CT atherosclerosis, has benefit because in these patients, even if they have known to have coronary disease, known to have atherosclerosis, understanding whether the ischemia, the extent, is also tremendously helpful. It is still a effective risk stratifying tool using stress CMR in another publication we reported. We know that in a randomized control fashion, in a randomized control trial fashion, this is also a tool that performed fairly well. In the MR Informed trial, published a few years ago in New England, randomizing CMR first or invasive FFR first in patients who have a clinical indication for a cath. This is a nine centers trial performed in Germany. It found that overall patients fare well, whether they have a CMR first or invasive FFR first in terms of symptoms and outcome. However, the CMR has aborted the need for about 1/5 of those patients for needing a revascularization. So MR was able, just like what SPIN showed, was able to keep patients on medical therapy safely and reduce them from having unnecessary cath or unnecessary revascularization in a subset of patients, which I think is important in the current era of low prevalence of disease. We did a cost effectiveness analysis a few years ago, assessing for 5 possible paths of different modalities to understand whether CMR can be cost effective based on the current performance utility of this technique. We felt that CMR certainly has a good value assessing the benefit of guiding, primarily because of reducing the cost of cath and being safe in guiding patients on medical therapy. However, there are challenges using this technique. What are the challenges? The challenges are it takes time to learn how to read these things. I have to say, I'm very comfortable reading these scans now, and I felt that I'm experienced. However, in my early years of training, I did recognize that there are cases that I probably shouldn't be as confident as I felt I was. So there's certainly a post-processing level of skills and also experience about looking at the pattern. Some of these are subtle. The most of the cases that can be missed are the not tight stenosis, the 70% that may be causing patients to have symptoms, 70, 80% maybe, but without any other collateral changes, without wall motion abnormality, without scars, but there is some subtle hypoperfusion. That you can see that between the readers. This is one study that was conducted in the UK, looking at their level of experience. Level 1 being just a month of exposure. Level 2 is several months. Level 3 is at least 1 year of exposure to these techniques. That there's a progressive increase, improvement in the specificity in diagnosing disease. And it's concerning because the level 1 really is really the specificity of calling for ischemia was fairly suboptimal. However, if you implement a full quant method like the ones I've shown, that takes away the need for uh, high experience in reading these. It brings in objectivity to interpretation of these perfusion techniques, and it makes it easier and it makes it more consistent across readers. So I think this is one important message that is one important message in my lab to make sure we have this tool a few years ago. Another thing is that we rely on patients may not have been compliant to their to following instructions of preventing of avoiding caffeine, or some patients just may not respond to regadenoson or adenosine. We historically will rely on, for those who are getting adenosine, we'll rely on so-called the splenic switch off sign, which is because of adenosine will actually cause vasoconstriction in the spleen. So you can see that if the patient has received adequate vasodilatation, you can see the spleen activity being low, spleen signal being lower, and that's also applied to PET now. PET look for signal activity in the same way. However, we now know that if you actually if you actually have implemented full quant, that's actually a much more reliable tool than looking for these collateral surrogates of vasodilatation, like such as blood pressure response, splenic switch off signs, or heart rate increase. None of them actually fare as well as just looking at the numbers to see the patient has several fold in all the pixels. Because we have pixelated map now, we can see all the pixels to see if it has achieved, some of the pixels have achieved adequate vasodilatation. It's more reliable as a tool to understand that the patient has been adequately stressed. So to summarize, that the benefits of mapping blood flow, because it scales the size of ischemic burden and that can overlay infarct burden accurately. From a diagnostic standpoint, it is a tool that allow you to have a much lower chance of missing ischemia from multivessel disease or left main disease uh, um, because of resolution issue. From a prognostic standpoint, ischemic burden is just better characterized by mapping technique, and we know that ischemic burden is the most robust risk marker across all the tools, EF, LV size, regional function. Across all of these tools we have, ischemic burden that is characterized accurately is the most important decision that reflects symptoms, but also outcome of the patient. Not only that, performing mapping allow a more objective interpretation, relying less on the reader's experience, and it can appreciate the adequacy of stress better. Here's a patient. Here's a patient that was that I was attending a few years ago. This is the beginning of the pandemic. He came in with chest pain, without any troponin or ECG elevation, and we were able to make a decisions in about 20-25 minutes. We can see he had no wall motion abnormality, no side, no infarct, but when we stress him, right away you can see, oh, there must be a tight LAD. You can see how dense the perfusion defect, affecting the basal, mid, anterior wall. So must be LAD lesion. But not only that, what was actually missed initially by me, that I didn't see that there's also a second perfusion defect in the inferior wall, infraseptal wall, and on the qualitative means. But because the mapping came out within literally several seconds in this technique, we can see that there's a second lesion, second perfusion defect. That is a two vessel problem. Now, could it be that the LAD is not providing collateral flow, or or is it true vessel disease? We don't know. So still end up cathing him. So it would show that he actually has indeed not only a tight proximal acute thrombus, but also a circumflex lesion that is that explains the second perfusion defect. So overlying another benefit that we have learned is that not only you can map the size, the pattern, the multivessel nature of disease better, by overlaying the infarct and the ischemic extents, we believe has a role as well. And this is we learned from the latest larger SPINS cohort. Again, retrospective data. So there's still a lot of questions to be answered, but we found that that could be useful. Now, what do I mean by that? What I mean by that is that this is a stress perfusion. You can see the perfusion defect in the inferior wall, infrasubtle wall. It affects the base, the mid, it extends into this, and then it looks reversible. But one thing about MRI gadolinium is that if you just inject a dose of gadolinium first and then you wait later to do the rest, that does not truly reflect ischemia because some of that region could be having lane enhancement. So you have to compare the stress against the actual infarcted territory to see if the size of the perfusion defect exceeds the size of the scar of the infarction. And that's become a standard now. There are many papers showing that that is a better way to look at these pictures. Now, when you look at that without the mapping, I would say it's harder for me to see, to appreciate if there is overlaying ischemia on top of the white area, the infarcted area. It's harder for me to see. I think that the size of the perfusion defect is very similar to the size of the infarcted bright lane enhancement. Maybe it's a little larger, but I don't know for sure. But with the mapping, that allow me to understand on a pixel by pixel level that there is coexisting fair amount of epicardial rim of ischemia extending further out into the epicardium, but also into other segments as well, including there's also another foci here. So this sort of understanding of the ischemic burden on a pixel by pixel level, I believe is a powerful tool. Why? When we actually look at the SPINS cohort, for one thing, is that having a high resolution assessment to pick out scars is a very unique thing by MR. A lot of endocardial scars are missed by SPECT or even PET because of resolution problem. The resolution of MRI is about 1.5 to 2 millimeters by lane enhancement. By PET is about 5, and SPECT is even a little worse. So MRI certainly has an advantage to pick out the missed subendocardial or unrecognized infarction. We look at the cohort of about 2,000 patients from the SPIN. This is from a few years ago. We found that these patients that got missed and turned out to have a UMI detected by MRI, they fare poorly. They're behaving just like they had a clinical recognized infarct. Part of the reason is because they were undertreated. The life-saving therapy, statin, aspirin, beta blockers, you can argue maybe ACE as well, if they have LV dysfunction, were used at 60% in these patients, primarily treated for other things, not because they were aware that they had an underlying infarct or CAD. So there's a substantial, they're substantially treated less and likely had been part of the reasons why they did not do as well. So it's important to look for that. But not only that, looking for subendocardial infarction, whether it's clinical or not clinical, is one thing. We also observe that the amount of pixels or amount of segments that is surrounding an infarct that is neighboring, that is basically in the neighboring segments of infarction, is actually very important. We observe that if a patient has adjacent or peri-infarct ischemia in an adjacent segments touching an infarction, the more they have, the more likely they're going to have events. So when we actually look at these cohort of now 4,000 patients, we look at the primary outcome of acute MI and death. And those patients who have peri-infarct ischemia, again, the larger the extent, the worse. But even just here, assessing presence or absence, provided substantial higher degree of association with primary events and composite events over having just ischemia or LGE, including the burdens. So it provides some increased understanding or a better appreciation that the risk of the patient, even adjusted for infarct and ischemia size per se. So is that because there's some sort of interaction between the perfusion as a trigger to underlying myocardial substrates of infarcted tissue, or is it because of collateral collateral or inadequately perfused coronaries? We don't know because not everyone gets half in this 4,000 patients, but we are pursuing further in this understanding and whether this should be used as a high-risk feature when we look at these scans. Hopefully, this is unpublished, but this will be hopefully it will be published in the next month. Diagnosing non-epicardial disease is also important, and it's a feature CMR can do. This is a case I was quite happy with the outcome. She's a college professor, very well read about her symptoms, known to have HCMs, was sent to the cath lab because of atypical chest pressure. Again, they didn't do an FFR, but they already told her that she needs to have an intervention of the proximal LAD. The patient did not want that, ended up seeing one of our genetic cardiomyopathy expert and referred to an MR. There is no way this is a LAD disease. Look at the amount of scar and endocardial fibrosis and the perfusion defect by the mapping that is so extensive. That is not just a LAD lesion. It affects the apex concentrically in the mid, all the segments, and less so, but the base as well. This on top of the LV that has so much endocardial fibrosis, make us think that this is a heart that has been subjected to high output outflow gradient. She has significant LVOT obstructions and subtotal hypertrophy. We sent her, ended up getting her on mavacamten. She felt better within a month. And this is a study from, I think, 3-4 years ago. She still continued to do very, very well. Symptoms have improved. So I think that this is sort of the kind of cases that we do improve the decisions on a daily basis. And I think this speaks to the need to understand on a pixel by pixel level how ischemia or hypoperfusion can help us make decisions. Just move on to we see often, these are all patients who initially thought to have coronary disease. CMR also see a host of these different diseases that turn out to have nothing to do with coronary disease. This is a 19-year-old with diffuse pericardial myocarditis. This is a patient who had, I believe she had lupus and had acute myocarditis. Sorry, this is not the lupus. This is the post-MI. This is, you can see that this is a patient who had a MI and had several weeks later had sort of post-pericardial injury syndrome. This is a patient with the lateral wall LGE, which is not a coronary pattern, but it's a parvovirus pattern affecting the lateral wall. This is a sort of a crazy case. The patient came in who was actually who didn't look very sick at all, but turned out to have a lump, had acute chest pain, ended up getting a stress test, stress MRI. But we saw this lump of it turned out to be a giant cell myocarditis on biopsy. So we see all kinds of other things as well. How do we deliver this? Why is this not being used? CMR is still used in only 1% of all stress testing for patients. For patient number wise, only 1% got a stress MRI for non-invasive assessment. We have not done well. Why? For decades now. Why is that? It's not because of lack of scanners. Okay, there are almost 12,000 scanners in the United States. We're number 2 in the world in terms of scanner to population ratio. Okay, just next to Japan. CT scan is we have almost as many CT scans. Again, the geographic distribution of these scans pretty much parallel the population density, the location of the population, which is along the coast, but also where the major cities are, which is, I think that's just a natural way to the need for having these technology. Compared to PET, we have almost 5 times more PET scans in the country. Why is it that we cannot deliver this more? We have to understand this problem better. The bottleneck, there are many bottlenecks. Again, we're talking about we're in a country of 35 MRIs per million, which is second in the world. But we have just having the machines doesn't mean we can deliver good care. We have 20 times more MRI machines in the US than trained physicians and technologists. So people are the problem. We don't have enough people who are trained. We don't have enough people who can run this or interpret this or even performing the scan. So at the Brigham, we have this similar but related but not exactly the same problem. Not only do I have lack of technologists to deliver the care, I cannot send them out to the peripheral centers where we get referral from Foxborough, Faulkner, and many other satellite sites. I cannot send them out there to performing the scans because there is other logistic factors. So we cover at the Brigham a 2.5 million patient coverage catchment area, and we need to deliver care. And historically, our wait time has been poor until about a year ago. Our wait time was about 2 to 3 months for a cardiac MRI. However, the growth has been, the need has been substantial, but you can see there's a bit of a jump. Indeed, this number should be about 3,200 if you count all the scans. So we had a jump. Again, I have to say, is really kudos to the team's effort to supporting an AI technology that you're familiar with. So AI-assisted CMR at Brigham. So we use the technique that that you're familiar with. That basically is a AI guided technique. It provides assistance. It locate the heart, the shape, and basically using the AI to align the cuts and the directions and the planning. Will develop a set of desired sequences so that every scan across the 5 major indications will be delivered in a cookie cutter fashion. Mike is very familiar with this as well. So I know that you also do some of these as well, your location. So, but with that, we not only would we scan it with the planned protocol, but it can also tune the sequence. It can look for optimization to improve the quality of the imaging, like this lane enhancement picture. It can monitor for changes and may apply in the future for future patients to benefit future patients. So the algorithm is more automated using the AI. And finally, in a subset, you can also perform the analysis of the LV and RV as well, which we have not heavily rely on. So out of this effort in the last 2-3 years, we've gradually tried to implement this over almost 5,000 patients, focusing on 5 major indications. These are the top 5 indications for CMR as listed in that proportion of the indications. Stress test was about 10%. Now it's up to about almost 20% because of the success of this program. The scan time, you can see that in red were before or if we don't apply the AI. The green or the blue is when we actually apply the AI. Now, there's a lot of variation, other factors as well, but suffice to say that there is improvement of scan time across all 5 major referral. The most challenging was actually complicated valve diseases, and that has actually been a game changer right away because the way we can locate the valves is so much better. But across all indications, the biggest one being cardiomyopathy, there is actually a substantial improvement of the way we deliver this. Not only about a scan time, but look at the standard deviation. So it's much more predictable what will happen throughout the course of the day compared to before when the variability of the scan time is so high, it becomes much less able to be managed. So our overall reduction of scan time is about 30%. give and take, primarily because we drive down the time wasted on finding the heart, re-prepping something, interruption when a phone rang, or other factors. The scan just runs itself. Our techs and our fellows and our attending just monitor, and that led to about a 30% reduction of scan time. And more importantly, I think an almost threefold improvement of the consistency of how we run the operation. Quality of the scan, because it line up itself to look for tuning and improvement of some sequences. Quality has also been improved out of a score of 0 to 5. The diagnostic quality is very good. Now, this is important for us because we only have one scanner. All the data I'm showing you about the AI is based on one scanner. That's all the access we have. That's a challenge locally, given the demand. Because of that demand, after we implemented the AI as a compulsory, mandatory default method since June of 2023, May, June, our wait time went from 5 weeks to 0 days. Pretty much over the first few days after we implemented that schedule, we were allowed to open up 50% more slots and relieve the backlog. It's now getting easier to get an MR than an echo at the Brigham. If you gauge, so in radiology, when working with our colleagues in radiology, we gauge by what is considered a success. If you deliver high quality that can make diagnosis to answer all the questions, that's criteria A. And if the scan can be done in less than 45 minutes, meaning the patient can get out of here in 45 minutes, that's considered a success. If you use that as a definition, then we implemented the succeeded proportion as shown in green here over time. You can see it. We started doing AI. This is before we have any of that. We have a 50% give and take, 50% success rate. But when we start using AI, trying it a year and a half ago, then you can see pretty much there's improvement. And part of that is cleaning up the protocol. But there's a gradual, but cleaning the protocol was done by now, done in about 2-3 months. But it continued to get better. The success rate continued to get better and better because it reflects the fact that our team is able to understand how to use the technology better. And now the success rate is approaching 95%. And therefore we open up 50% more slots using the same single system, cardiac MRI system, where we can deliver about 3,000 scans per year. We relieved the backlog. There was a lot of congestions on inpatients and outpatient, and no one was happy for a while. And because of this effort by the team, the hospital sees it as a benefit to patient care, and we actually indeed won a small local award. So in summary, a stress CMR captures heart function, stress and rest perfusion, and viability in less than 30 minutes now. With AI, even better with the AI. In the current era of low coronary disease prevalence, and we have effective guideline-directed medical therapy, CMR is indeed a highly effective functional myocardial physiologic tool to guide us about how to keep patients on medical therapy, and in the in a minority of cases refer to invasive referrals. And I would argue that most of these cases can just make a decision non-urgently. In the new ACC/AHA guideline, CMR has class 1, not only for chronic chest pain, but we also have quantitative assessment for patients such as patients with microvascular disease, such as along the same line as PET. CMR blood flow mapping performed offline allows accurate detection of ischemia extent, which is a robust prognostic and guidance tool, and also detect multivessel disease as well. So with that, I hope that this is interesting and helpful to you in some regard. And thanks again for the invitation to let me speak today.